Hello and welcome to Filibusters in Fine Print, where AMGA's public policy team gives you the insider view on healthcare regulations and legislation. Thanks so much for joining us for the latest from Washington, D.C.
Good afternoon, and live from Washington, D.C., this is Filibusters in Fine Print, AMGA's public policy podcast. We have all the policy news that's fit to print. I wonder if that's a copyright violation. Well, I guess we'll find out. We are very, very pleased. Oh, I did not start the stop. What doesn't start? Okay, good. Lauren's helping me with my phone. Thank you. We are very pleased because we have an actual guest star to be on our podcast. Dr. Scott Hines, endocrinologist. I have an A1C of 6.1, I believe. And
I'm pre-diabetic.
So who was the real star that backed out and then you wound up with me?
Well, we have Beth Afferback later.
Oh, okay.
But who was the real star? Quite candidly, but
You don't
Strong work on the A1C.
we're doing, that's right. Where's those cookies? And Chief Quality Officer for Crystal Run, is that the right title? And importantly for all of us, the chair of the AMGA Public Policy Committee. We're thrilled to have you. You've been a policy expert for a number of years, and happy to have you.
No, thanks for having me. I'm excited about being here, talking about the Public Policy Committee and the MACRA task force that we've been working on.
So today's topic is the MACRA Value Task Force, and that is a task force that we created 2 years ago, basically to coincide with actually 8 members of Congress asked AMGA and others if we would actually draft recommendations on how to revise and reform the MACRA statute, which, as you all know, was the Part B reimbursement mechanism that Congress passed 10 years ago. And they asked us to look at that. And instead of giving our usual, not our usual, but instead of doing a 3-page letter, we actually spent 2 years and created a task force that would actually provide recommendations on how to reform MACRA, but also how to better transition the whole system to value. And that was, Scott was the chair, of course, because he chairs everything in the policy realm. Dale Drevna is a staff director.
That's correct. Yeah, it was. That was me.
He had a much lesser title in the original publication, and that was
Through several rounds of editing, we landed on staff director.
that was a major point of contention, and
we almost vetoed the whole thing. That's why I'm walking from this project.
Indeed. So
Titles are free.
titles are free. That is true. That is true.
Yes.
And we're also joined here by Lauren Latney.
Hi, I have an A1C of 5.2.
Even stronger work.
Are we doing that? Mine's 5.9.
Is it really?
I'm in the pre-diabetic range.
Yeah.
But my PCP is like, eh.
I'm concerned.
It's like these DC doctors aren't very good. Anyway, well, back to our task force. We won't ask Scott what his A1C is.
Sure.
I don't go to doctors.
Don't trust them. Well, in any event, so let's talk about the task force, which Scott chaired and you directed. Daryl.
Right.
And
The man behind the curtain.
not so much. Please, explain the work. What did the task force look at? What did they end up recommending? And was there a theme behind what you all did?
Sure, I can take a first cut of this. The task force, Chet mentioned the idea that we needed to be responsive to Congress in a thorough and, thought out manner, and not just yet another white paper from some DC think tank that's going to get shelved and collect dust and become, we want something that's going to live on folks' coffee tables for years and years and years. So we we gathered a bunch of AMGA members who were really interested in policy and sat down and came up with a framework for how are we going to tackle these issues. And I remember it was right before Capitol Hill Day 2 years ago, we had our first meeting, and it was just a brainstorming session. If you look at my notes now, it looks like that scene from A Beautiful Mind, where it was just like crazy scribblings everywhere, and it was just fix the system.
Are you saying you have a beautiful mind?
No, I was thoroughly confused. And it's like, I need to start shopping my resume because this is never going to get off the ground. But it did. We really came together, and through a series of meetings over the weeks and months, we, honed down on really specific topics that really resonated with the members of the task force, and they were savvy enough and dedicated enough to this that we actually took into consideration what was actually going to be feasible and resonate with members of Congress.
Yeah, and I think part of the reason why we are so focused on this right now is that MACRA does have some benefits, but there are a lot of areas in MACRA that are not living up to what we thought they were going to. And when we're being asked for input on how it can be improved, now is the opportunity to do that, because at the end of 2026, the bill will expire and it needs to be replaced with something. And when I ask anybody what happens if it's not replaced, I'm told not to ask that question. So I don't think anybody has any idea what's going to happen if it doesn't get replaced.
It like all life as we know it ceases to exist.
Dogs and cats living together.
Exactly. Mass hysteria. But that would be Lauren, what would, like, Congress, you always say, like, they do things at the last minute. So are we going to be...
It probably, but they are also working behind the scenes. Like last year, we were AMGA. We did a lot of work talking to committee staff, Energy and Commerce, Senate Finance Committee, about MACRA reform. This is something they've been interested in for a while, but the political will is not there yet. Political will never shows up until the absolute last minute, but they are doing some groundwork. And so sharing some of the previews of the work that the task force is doing and now having this really wonderful document, I think is going to help us. It probably will also be a relief to staffers when we bring this back up again, because it's not reconciliation. It'll be a completely different topic. And I think when you're looking at it's happening on the Hill, everyone who wrote MACRA, most of them are gone. Staffers, members of Congress. And so you're dealing with a group of people who were not a part of the writing process of this. Some of them don't really know MACRA. And so you're also dealing with education of staff and also dealing with staff who want to create their own thing. And so that's going to be interesting moving forward of how we engage with these staffs, because they're going to have ideas and we're going to have a reality check for them. So, and that's how the policymaking process works.
And I think one of the things that's really key about this is that we came up with solutions. We didn't just go asking for stuff. We didn't go asking for more money or less regulations, although we did ask for those things.
Yeah, we did.
But in addition to those things, we also offered solutions on how we can get patients better engaged. How can we provide care in a way that's more holistic and patient-centered? And so I think that this is a really good balance of offering solutions in addition to identifying the pain points that we're currently experiencing.
Yeah. So two thoughts. One, I thought what the task force did very well was, as you developed recommendations, you also made sure the Hill was aware. So I know, Scott, you met with Hill staff last Capitol Hill Day. So we're constantly having discussions with the committee staff, so they knew where we were. They liked where we were going. And so there was a very sort of a symbiotic relationship between the work of the task force and the Hill staff, which should make it easier once reconciliation and then funding the government is done at the end of September, October. Yeah. So at that point, that's when Lauren, you and Jamie and Alicia start working.
Oh, so I can start working right now.
We have 5 people in the department, so no, let's not make it down.
Cue the summer vacation music.
It was amazing how quickly I booked my vacation. Once this task force was like at the printer, I'm like, yep.
It's gonna be a very, very quiet office in the next few weeks. But the second point, let's talk about the work of the task force. So I believe there are 6 pillars,
right?
Of which the task force spent a lot of time on and made recommendations around those. Can you talk about those 6 pillars, what they are, where we're going, just so folks know the work that you all did?
Sure. I think the first one, and this came out of one of the very first or second meetings. To Scott's point, we didn't talk about like increasing reimbursements and that sort of thing. That was way, way down the road. The first one was, how do we get our patients engaged? So I think that the first pillar is patient engagement. You want like actual patient engagement, not just a check the box exercise. I talked to my patient about X, Y, and Z. How do we get them? What barriers exist between patient and their provider, and how do we eliminate those so they can make informed choices?
Yeah, I think, when you think back to all the different models that have been rolled out through the years, there's always a focus on what do the providers need to do in order to be engaged, and what do the insurance companies need to do to be engaged? And there's really no focus on what the patients need to do to be engaged. And I think the general thought is, well, patients are going to just naturally be engaged because this is about their health, and they are going to do everything they can to be healthy. And but unfortunately, life gets in the way, and there are a lot of different factors that prevent patients from being able to be as engaged in their care as they want to be and should be. And so some of the ideas that we came up with were around potentially reducing cost sharing for patients for services that are linked to preventative care. Now, I realize many of those things in the ACA are covered, but there are things that are outside of the ACA, things that are outside of what the USPSTF may endorse as a level A recommendation, that if patients will be engaged around and their providers explain the importance of, that they may actually be better equipped to do those things. And also thinking about ways to incentivize patients to make sure that they have all of their health caring screens and preventative services. So if you have all of your cancer screenings, and if you have diabetes, you have all of your diabetes measures covered, then maybe you have less cost sharing or less of a premium moving forward. So again, ways to tie patient engagement to outcomes.
And we even talked about actually paying patients to be healthy. I think that's part of the recommendations. And that's something Dr. Oz took a look at 15 years ago when I was in Cleveland, and he supported it back then. Presumably we have a ready audience around that. And
I think so.
Daryl, we just heard you do a panel where you talked about one of the new CMMI mindsets is an engaged patient and an active patient. And so this chapter should have a welcome audience.
I think it'll resonate.
CMS.
I think it'll resonate with the new leadership team over at CMS. Absolutely.
That'd be good. All right. So patient engagement, what else did we talk about?
Yeah, sure. Our second pillar is really looking at health outcomes and thinking about medicine more holistically. So one of the challenges with the way that the medical system is currently set up is that it's really transactional. It's in the fee-for-service model, you're just thinking about the care that's being provided and not whether that care is actually leading to better outcomes. And so we want to focus on a system that incentivizes outcomes to make sure that the care we're providing is actually helping patients and is helping to reduce their burden of disease and improve their quality of health. And it shouldn't matter whether those patients are living in cities or living in rural America or what their ethnicity is or race or anything. It really should be one single focus around outcomes and what can we do to better support those outcomes.
Makes sense to me. The third pillar, I believe, is end of life. I know Dr. Averbach is going to spend a lot of time on that.
Right. We're going to have a
next.
whole very special episode.
Yeah, really. We didn't think Scott could handle this. So we had to quickly shift to Dr. Averbach. Yeah.
We do. Yeah. No.
It's a little too heavy for me. So yeah.
If I don't fix my A1C. But no, it's, and we had a panel discussion about this earlier today. At part of our value roundtable, and just having these conversations and changing the culture around, frankly, death in this country, and how we prepare folks and make sure they have and support their choices, whatever they may be.
Yeah, and I think one of the barriers to end of life care is just making sure providers have the time to be able to have these conversations with patients. And again, when you're in a system that is just transactional and not thinking about the whole patient and thinking about overall outcomes, sometimes those things aren't a priority. And I would argue that these are usually, or should be, the biggest priority when talking to patients who have a lot of chronic illnesses.
I agreed. Okay. And then after that, we talked about regulatory and legislative burdens to care delivery.
This was, I think, probably my favorite session of
this
the
is how
meetings.
became
Daryl was like a little kid on Christmas morning. Every time we threw out a regulation, he's like, "Ooh, I like that one."
It's like a 42 CFR, this one, and you sit there with a red pen like, that's got to go, that's got to go.
This is how he made staff director.
Yeah. It's exciting. It's good to find a purpose in life. And I found mine with this task force, which, we can have another episode.
Just to say, I'm sure his wife and child really enjoy it.
Yeah. You joke, but my kid was going to give he had to give a PowerPoint presentation as a fifth grader. He's like, can I do it on the anti-kickback law? I'm like, oh, hanging around me too much. But no, the regulatory, it's a meaty chapter for the task force, and we talked everything from about what requires a physician's signature? How many quality measures are there? How are they reported to this payer versus that payer? Excuse me, do we need to take a look at some of the rules that are still around because the program was built in 1965 and the way care delivery has evolved and, improved over the years? The rules and regs just haven't kept up.
And I think just like the patient engagement chapter, this chapter is going to be well received, because if there is one of the encouraging things coming out of HHS, it's that they really are interested in reducing the regulatory burden. And just to give you an idea of some of the ridiculousness in these burdens. So believe it or not, nurse practitioners need a physician to sign an order to get diabetic shoes for their patients. They can prescribe controlled substances, they can take care of patients in the ICU, they could do all sorts of things, but they need a physician to sign something saying that they can prescribe diabetic shoes. These are some of the ridiculousness that exists right now, and some of the things we're trying to cut through.
I think a story like that, we go into a meeting with CMS and mention that's their eyes are going to go, wait, what? That's going to resonate.
Yeah. So Dr. Hines will be with you at the CMS meeting?
With a pair of shoes.
I think we all want to see that.
I won't be wearing this. Although it reminds me,
Jill and I will be.
My very first medical assistant, she was like 19 years old, right out of school, and she said, "You can prescribe shoes? Like any shoes that people want?" And it's like, no. Trust me, the shoes I could prescribe, you would not be caught dead wearing.
That's right. Well, we went from shoes to small and practices that serve underserved populations.
Right.
I think the task force was very concerned about making sure the small practices also had a chance to move to value and had care delivery burdens taken off their plate as well. Is that safe to say?
Yeah, absolutely. I think the task force was very aware of some of the struggles that came out of the MIPS program because of the exclusions and the way the system worked or didn't work, depending on how you want to characterize that. And they wanted to present something to the policymakers on the Hill that this is a model, this is a system that will work for everyone, and we're trying to get away from the winners and losers mentality or system that was set up in MACRA, in MIPS originally, and let's have everyone succeed, whether they're in the big city or a rural provider.
It's so interesting because this one is us against, I think, everybody else.
Yeah.
Recently, there was a meeting with the GOP Dot Caucus. Jerry Pinsell, our CEO, got to talk about some issues, and he was the only one talking about the need for everyone to participate. Everyone else was saying we want to get rid of all these things. We think MACRA is sort of a failure. We want all these sort of different systems that are against the whole purpose of MACRA. And so it's a conversation that's willing to be had by us, and I think we're ready for that fight.
And I think this was one of the more interesting chapters because we came up with some pretty interesting and novel ideas on how to support rural practices. For example, things like setting up regional hubs that small practices can tap into for care management or care navigation services, things that I think a lot of rural providers realize would be helpful for their patients, but they just can't afford to invest in on their own. So giving them an opportunity to invest in it in scale. I think some of these ideas can gain some traction.
And that was a great idea. It was largely because it was mine. Okay, very good. So we are at almost 18 minutes, and Lauren is looking at me like we got to wrap this thing up. So we have one more chapter, sustainability,
Right.
which we purposely put at the end.
We did. As staff director, I made the call. So we can't lead with this one. But if you want to succeed in any of these, whether it's engaging your patients or bringing in the small and underserved practices, really having a frank conversation about end of life and what that looks like, you need a predictable and stable financing model, right? Otherwise, the resources simply aren't there for our groups and systems to do this valuable work.
Yeah, because a lot of these services that provide patient-centered holistic care are not services that are directly covered in the current fee schedule, and so we need to find ways to be able to afford these things. Frankly, they're all great ideas, and I think a lot of patients will benefit from them. But if there's not a way to pay for them, then sadly, they're not going to be leveraged.
Well, this is great. And congratulations on the task force work. It was 2 years. It was intense. You all did a wonderful job. The print version is fantastic. 300 copies. You'll use it on the Hill tomorrow and with Hill staff afterwards. So
it's a document that's going to be in probably the Library of Congress one day.
It's a Constitution. It's a living, breathing document.
Signed. Yeah, get Daryl and Scott to sign them.
Oh yeah, I'll be in the
rates go
Dubliner
up.
like later on. In
Make them
Barnes
for
and Noble.
thousands on eBay.
The Dubliner is right down the stairs, so I'm sure we'll all be there. Well, thank you very much, Dr. Hines. A pleasure to have you here.
Thanks for having me
Special
back.
guest, not as special as Dr. Averback, but great to have you.
I'm happy to be her warm-up back.
And Beth is next. And with that, we'll say thank you, and you all have a good day.
Thanks for joining us for Filibusters in Fine Print. This podcast was brought to you by AMGA. For more information about AMGA's advocacy efforts, visit amga.org/advocacy.